Hi everybody, and welcome to our module on meningitis. So let's review what the meninges are. Beneath the bone of the skull is the dura mater, and this is thick material that covers the skull, and that's why it's called dura, because it's durable. Beneath the dura is the arachnoid and then the pia mater, and these are much thinner than the dura mater, and the arachnoid and the pia are often called the leptomeninges, and the dura, arachnoid, and pia together are all called the meninges, and that's what surrounds the brain and spinal cord. Meningitis means inflammation of the leptomeninges, and usually it's viral or bacterial, sometimes it's fungal, and very rarely it can be caused by things like cancer or sarcoid or inflammatory diseases. The symptoms people with meningitis get are fever from the inflammation and headache from inflammation of the leptomeninges around the brain. And then patients with meningitis often have photophobia. The mechanism of this symptom is not clear, but bright lights will bother someone who has meningitis. They'll want to sit in a dark room. And then a specific sign of meningitis is nuchal rigidity. So the nape is the back of the neck, and the nuchal area is the area related to the nape. So nuchal rigidity means it hurts to move the back of the neck. Before the modern era, to diagnose meningitis, you had to use the physical exam, and there were two signs that were considered important for diagnosing meningitis. The first one is called Koenig's sign. So to do this, you lie the patient on the table, and you bend the thigh at the hip with the knee at 90 degrees, and then you try to straighten the knee. And this is painful. The patient will say it hurts, and that's because you tug on the meninges when you do this. The second sign is called Brzezinski's. So you lie the patient flat, you lift their head off the table, and they will involuntarily lift their legs to try and relieve the pain and discomfort. Both of these are signs of what's called meningismus, which is irritation of the meninges. Usually that's for meningitis, but you can also see this in subarachnoid hemorrhage. I've never seen anyone do any of these things anymore. They're largely historical. The way we diagnose meningitis in the modern era is by suggestive signs and symptoms, and then we do a spinal tap. So this is how you do a spinal tap, which is also called a lumbar puncture. You either lie the patient on their side, like in this picture on the left, or you have them sit up and bend forward like this picture on the right. And recall that the spinal cord ends at L1 or L2, so you want to be below that area. If you were at or above that area, you'd push your needle into the spinal cord and cause nerve damage. The ideal space is L4 or L5, particularly because when the patient bends forward, this is the widest inner space, so it's easy to get the needle in there. And the way you find it is by feeling for the iliac crests and then drawing a line between them with your finger. So on this picture on the right, this man's iliac crest might be here. You could feel that with your fingers and then draw it across to the other one, and that's where you want to go for L4, L5. When you push your needle in, you're going to cross several structures that it's high yield to remember for your boards. The needle will go through the skin, the ligaments, the dura mater, and the arachnoid, and then it will enter the subarachnoid space where you'll draw fluid from. Importantly, it does not pierce the pia, so don't get that wrong on a test exam. You can also check something called an opening pressure when you first put your needle in by measuring the pressure of the fluid in the spinal canal. To do this, the patient has to lie on their side. If they're sitting up, it'll falsely elevate the pressure. And a normal opening pressure is up to about 250 millimeters of water. If you get a pressure that's higher than this, it can be seen in some forms of meningitis, like bacterial and fungal or TB. And then it's also what's seen in hydrocephalus. So when you diagnose hydrocephalus or any cause of raised ICP, you have to do an opening pressure on a spinal tap. You can also drain fluid out to lower the intracerebral pressure, and this is a therapeutic maneuver done for people with pseudotumor cerebri and some patients with cryptococcal meningitis who have very high pressure in their spinal canal. There are some complications of meningitis that you should know about. It can cause death. Every once in a while there's an outbreak of meningitis at a college campus, and sometimes a young, healthy college student will die, and this is obviously very tragic. You'll often read about it in the papers. You can have scarring after meningitis, which affects the arachnoid villi and their ability to absorb cerebrospinal fluid, and you will get hydrocephalus from this. And I talk more about this in the module on ventricles and sinuses. You can have hearing loss after meningitis, and you can also have seizures after meningitis. And this is usually from bacterial meningitis, which is the more severe form. So if you're working in the emergency room and a patient comes in and you believe they have meningitis, you want to treat them with antibiotics. The problem is culturing their spinal fluid to determine the bug can take days, and you can't wait for that to drive your choice of antibiotic. So you're going to choose the correct drugs based on the patient's age and comorbidities and based on what you see when you do a quick analysis of the spinal fluid. And we'll talk about those things now. So after you do a spinal tap, you send the spinal fluid for four things. You want to know what cells are in it, how much protein's in it, how much glucose is in it, and then you want it to be sent for a culture. But of course the culture will take a couple of days to come back. So this slide shows the CSF findings in different types of meningitis, and you should make sure you're familiar with the slide because it's very high yield for all your step exams and even for internal medicine and emergency medicine boards. So in bacterial meningitis, you will see increased levels of polymorphonuclear lymphocytes, or PMNs, and that's what you'll see in the cell counts. The protein level will be increased and the glucose level will be low, and a lot of people remember this by thinking that the bacteria eat up the glucose and cause the level to be low. In viral meningitis, you see increased numbers of lymphocytes in the cell count. The protein level is normal or slightly increased, and the glucose level is normal. And then finally, in fungal or tuberculosis meningitis, which are very rare, you see high levels of lymphocytes, high protein, and also low glucose here. So normal CSF is clear. It may have up to 5 lymphocytes, but that's it. It normally should be sterile and have very few cells. It will have under 45 milligrams of protein, and it usually has more than 45 milligrams of glucose. The glucose level in the CSF is about 2/3 of the blood glucose, and a normal blood glucose is about 80 to 120. These are the antibiotics we use for meningitis: ceftriaxone, vancomycin, ampicillin, and gentamicin. And the reason we use these is because they all have good CSF penetration. This slide lists the causes of meningitis by age group and the antibiotics you use to treat them, so let's go through it carefully. So we'll start over here on the left with the newborns from 0 to 6 months. They often get meningitis from their mother in passing through the vaginal canal, so they have unusual bugs that cause meningitis. The first two are group B strep and E. coli, and then the last one is listeria, which affects people with poor cell-mediated immunity, so it tends to affect newborns and also the elderly. For children, young adults, and the elderly, the most common cause is strep pneumo in each group. It's also the most common cause overall. For children and young adults, the second most common cause is Neisseria meningitidis. And then what's different for children and young adults are the third and fourth most common cause. For children, it's H. flu and then enteroviruses. For adults, it's enteroviruses and then HSV. We'll talk about all these bugs more in this module. For the elderly, after strep pneumo, the most common cause is gram-negative rods, and then they tend to get listeria because just like newborn babies, they have poor cell-mediated immunity. So generally, the treatment for most people you're going to see with meningitis is ceftriaxone plus vancomycin. That treats kids and adults. The only exception is in the elderly, you add ampicillin to cover listeria. For newborn babies, you're going to treat them with ampicillin and gentamicin. They have a special regimen that we use to cover those bugs. So now we'll talk about each of those bugs in a little more detail. So Streptococcus pneumoniae is the most common cause of meningitis for all ages. It's a lancet-shaped gram-positive cocci in pairs, and you can get meningitis from this bug following a strep respiratory infection. So watch for a board question of someone who had a cold or pneumonia and then gets meningitis. People who are at increased risk are asplenic patients, so you need your spleen to clear this bug from the bloodstream because it's an encapsulated organism, and asplenic patients have trouble doing that. Sickle cell patients are what we call functionally asplenic. So they have a spleen, but it's not working well because of the sickle cell anemia. And then for reasons we don't totally understand, alcoholics have a very high risk of getting strep pneumo, both pneumonia and meningitis. And strep pneumo causes other infections besides meningitis. It also causes otitis media in kids and pneumonia, and it can cause sinusitis. Neisseria is a gram-negative cocci in pairs. It's often called a diplococci, and it's transmitted by respiratory droplets. It gets into the pharynx and then the bloodstream and then winds up in the CSF where it causes meningitis. There are a lot of asymptomatic carriers, but for reasons we don't totally understand, this sometimes causes severe disease in certain individuals. These bugs have a polysaccharide capsule that prevents phagocytosis. That's one of the virulence factors for this bug. Then they also have something called a lipooligosaccharide, or an LOS, in their outer membrane. And this is like the lipopolysaccharide in gram-negative rods. It's an endotoxin with many toxic effects on the body, and it activates a severe inflammatory response, and is part of the reason why this can be so deadly. People with Neisseria meningitis can get bacteremia complicating their meningitis, and this is called meningococcemia. And this is a very serious disease. It can kill people easily. It causes sepsis with fever, chills, and tachycardia. Patients can get a rash all over their body. They can develop disseminated intravascular coagulation, and then they can get a special thing called the Waterhouse-Friderichsen syndrome, where they have destruction of their adrenal glands. And what you're going to see in the patient is hypotension, so you need cortisol to maintain your blood pressure. So if a patient with meningococcemia suddenly becomes hypotensive, you have to think that they may have just destroyed their adrenal glands. And this is life-threatening, and it's one of the ways young people who get meningitis can die. For reasons we don't completely understand, Neisseria can cause outbreaks, especially in places where people live in close quarters like dorms and barracks. And this is scary because it can affect young, healthy people like college students. So patients who get infected need to wear a mask, and that's called droplet precautions, and it prevents their respiratory droplets from getting to other people. And close contacts, like someone's roommate at college, need to take prophylaxis. So the classic prophylaxis drug is rifampin, but rifampin changes the color of your tears, and it can change your contact lens color, and a lot of people don't like to take it. So many people just take ciprofloxacin, which is more readily available. And there is a vaccine for Neisseria meningitidis. It contains the capsular polysaccharides, which yield antibodies from the body, and it's used in high-risk groups. Next, let's talk about H. flu. So this is a small gram-negative rod. It's a coccobacillus, and it enters the pharynx and then the lymphatics and the CSF. And hopefully you all know by now that this is not what causes the flu. The flu is caused by a virus, not this bacteria. So the most important thing to know about H. flu is that it almost never causes meningitis anymore because of the vaccine. It was once the most common cause, but now we give vaccines to babies so that they never get it. And if you're going to see H. flu meningitis, it's going to be in someone who's unimmunized, probably an immigrant from another country where they didn't have their vaccinations. Listeria is a gram-positive rod. It's a facultative intracellular organism. It has this very special mobile quality called tumbling motility. You should go to YouTube and watch this. So instead of the bacteria sort of swimming around like this, it tumbles from side to side and moves across the petri dish. It multiplies in cells when people have poor cell-mediated immunity, so that's how you can remember that it's going to infect people like neonates, people with HIV and organ transplants, and then often the elderly. In adults, they usually get this from contaminated food, so they eat undercooked meat or unwashed vegetables, they can get listeria. They can get it from unpasteurized cheese and milk. So in the early 1900s, when people started to live in cities, they started to eat milk that was days old from faraway farms, and many of them got listeria and tuberculosis and lots of other bacteria from this old milk. So pasteurization is a process by which you warm the milk up and then cool it off, and it gives it a much longer shelf life. So almost all the milk you buy nowadays is pasteurized, and that's why you don't get sick from it, even though it does have a due date on it by which you should use it, because it can only last for so long. So unpasteurized cheese or milk can give people listeria. And this bug likes cold temperatures, and that's one of the way it's cultured is to put it in cold temperatures and see if it grows. And so in neonates, this is a common cause of meningitis, and that's because the babies get it from transplacental or vaginal transmission at birth. So group B strep is called strep agalactae, and it's gram-positive cocci in chains, not in pairs. It's catalase negative. All streptococci are catalase negative, and then it's beta hemolytic. So that's the pattern it exhibits when you put it on blood agar is beta hemolysis. And then there's a test called the CAMP test, and CAMP, the letters stand for the 4 people who designed the test. And it tests for a CAMP factor, which is only found in group B strep, so that's another way it's identified in the lab. It's the most common cause of meningitis in newborns, and it's transmitted when the baby passed through the birth canal, and some mothers are given ampicillin during labor to prevent this from happening. And keep in mind that babies who have meningitis may not have classic symptoms. They're not going to complain of photophobia and neck pain because they can't even talk. So they're going to have hypotonia. They may have a weak sucking reflex. They can get bulging fontanelles and sunken eyes from the inflammation in the meninges, and they can have poor feeding. So when you have a newborn baby who's failing to thrive, one of the things you sometimes need to do is a spinal tap to rule out meningitis. So E. coli is the second most common cause of meningitis in neonates. It's a motile gram-negative bacillus, and a bacillus and a rod are basically the same thing. One of its important virulence factors is that it has this thing called a K.A.N. capsular antigen. This inhibits complement and basically allows the bacteria to avoid your immune system. It grows on certain media that it's high yield for you to know for your board, so it'll grow on blood agar, which is sheep's blood as the medium. It will grow on MacConkey agar. MacConkey agar selects for gram-negative bacteria, and basically if something grows on MacConkey agar, then it's an enteric bacteria from the GI tract. And it also grows on something called eosin methylene blue agar. So those are all the causes of bacterial meningitis. Now we'll talk about viral meningitis. And the old name for this is aseptic, because it used to mean you have the signs and symptoms of meningitis but no bacteria grow. It's usually caused by enteroviruses. So look for viruses like Coxsackie virus, echovirus, and poloviruses as answers on your boards for what causes viral meningitis. It's self-limited. It's sort of like a cold of the spinal canal. That's the way I think of it. You just give people supportive care like Tylenol and anti-inflammatories, and it usually goes away after a few days. All these bugs that cause it are single-stranded RNA viruses, and it's high yield to know that. It's also high yield to know that fecal-oral transmission is the way by which people pick up these bugs. There are some other viruses that can very rarely cause meningitis, different than the viruses I just mentioned. Those include HSV, and we'll talk about this one in a minute. HIV can cause it. West Nile virus and sometimes varicella zoster virus can also cause viral meningitis. So let's talk about herpes simplex virus. There's two important types. The first one is called HSV1, and this is what causes oral herpes, and it can also cause eye infections like keratoconjunctivitis. And it also can cause encephalitis, which we'll talk about in a few slides. And always remember that herpes simplex virus loves to infect the temporal lobe. That's high yield to remember. Now, herpes simplex virus 2 is what causes genital herpes. But one thing that's important to know is about a third of patients who get diagnosed with genital herpes have clinical findings of meningitis, like headache, photophobia, and meningismus. And then people who have HSV2 documented meningitis, about 85% of them have genital lesions. So they kind of go together, the meningitis from HSV2 and the genital herpes. Now, a lot of people remember that HSV1 affects above the belt, like the mouth and the eye, and HSV2 affects below the belt, like the genitals. The only exception to this is the meningitis business. So HSV2 can cause meningitis, and HSV1 will cause encephalitis. And you can treat both of these bugs with acyclovir, valacyclovir, and famciclovir, the antiviral drugs. So usually when someone has viral meningitis, you don't do specific testing to figure out what the virus is. There's a couple of exceptions to that. If you think they might have HIV, then you obviously test their blood for HIV RNA and HIV antibody. If you suspect herpes simplex virus, you sometimes test for this, and antivirals can be given. For the other viruses, you usually only test if there's special reasons. Tuberculosis meningitis is really rare in the modern era, but it used to happen a long time ago when TB was more common. You can see it in immunocompromised people. Remember that the spinal tap will show high lymphocytes in TB meningitis, high protein, and low glucose. An important thing to know is that you need multiple CSF samples for this because it's hard to culture TB. You can sometimes do what's called an AFB smear, where you put some of the CSF on a slide and put a stain on it and look for acid-fast bacilli. It's a quick way to test for TB, but it's often negative. What you really need to do is do something called nucleic acid amplification test. These use genetic techniques in PCR to try and detect the bug. So encephalitis is a related condition to meningitis, and encephalitis is brain inflammation. So when you see a patient who looks like they have meningitis, they have nuchal rigidity and fever and headache, and you think they have meningitis, you need to make sure they don't have any of these symptoms like altered mental status, motor or sensory deficits, altered behavior, personality changes, or speech and movement disorders. If any of these things are present, it suggests they actually have encephalitis, not meningitis. And when that's the case, HSV1 is one of the most common causes. So besides HSV1, there are other viruses that sometimes cause encephalitis. Varicella can do this, the bug that causes chickenpox and shingles. And then there are a bunch of mosquito viruses that cause this. This will sometimes make it in the paper when someone gets a mosquito-borne illness that gives them encephalitis and they get very sick. So St. Louis encephalitis, Eastern and Western equine encephalitis will do this, West Nile virus, and another bug called California encephalitis. All of these get in your body when a mosquito bites you and then cause encephalitis. I've listed here some other very rare causes of encephalitis. You'll never see any of these clinically, but they're worth knowing for your board. So Lassa fever is a bug spread by mice, and it's a nasty, nasty disease that's similar to Ebola. So people get encephalitis, but they also get many, many other symptoms. So they get inflammation of their lungs and their GI tract and their heart and their eye, and they can get very sick and die from this. Measles doesn't happen in the U.S. anymore because of vaccination, but people from other countries or unvaccinated children can get measles. And then what happens is they survive, but 5 or 10 years later, they can get something called subacute sclerosing panencephalitis, where basically they get inflammation of their whole brain. It's usually fatal. It's very hard to treat. And remember, it will come on years after the initial infection. Naegleria fowli is a protozoa. It's actually an amoeba, and it's found in freshwater lakes. People call it the brain-eating amoeba, and this is really rare, but if you're going to see it, it's going to be a board question where someone's been swimming in freshwater lakes, and then they're going to come in with fever and mental status changes and encephalitis. Basically, the bug gets in through your nose and then goes into your brain. And then patients with end-stage HIV and AIDS can get subacute inflammation of the brain. It's called HIV encephalitis. They have to have a very low CD4 count, usually under 200, and they get these multinucleated giant cells all over their brain, and they get brain atrophy, and that's HIV encephalitis. And that concludes our module on meningitis.